Welcome, everyone. Welcome to our monthly webinar from the Health System Performance Network, focused on OHTs, Ontario Health Teams. If you are joining us, please let us know that you're here. You can do that by going into the chat and making sure that you've clicked to everyone, not just to hosts and panelists. Make sure it is to everyone. And then you can just type in your name and where you're from. Either if you're from outside of Ontario, just what geography, and if you're from inside Ontario and you're attached to a team, maybe which team you're with. And I look forward to welcoming everybody in now. Sarah Weberman from Connected Care Halton, the first in. Hardeep from Middlesex, London. Here we go. Crystal Miller, Cheshire, welcome. Welcome, Sam from Durham. Mike from Rise, thank you very, very much. And Colleen from All Nations. Yeah, I'm actually getting to know people quite well, and these are many names that I'm familiar with, and some of whom have been on these webinars sharing with us. Lisa from Madawaska Valley Hospice. That is amazing. I like to get out to canoe, and I did get out for a week in Madawaska canoeing last year in Whitewater. Pat Jones from OH at Home, Waterloo. Welcome. Louis from Flemington Park. That's really great to have you. I know about the neighborhood models that are happening in there. Pat Maurice from East Toronto. Khadija from Toronto as well. Welcome. So we have people from all corners of Ontario, from Ontario Health Teams, from Ontario Health, and localities. Welcome to you all. I'm so pleased that you're able to join us today. I am speaking to you today from the University of Toronto. And for thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, the Mississaugas of the Credit. And today, still a meeting place of many Indigenous peoples from across Turtle Island, and we're grateful to have the opportunity to work on this land. And I know that while we have buried some of the natural original land, Tattle Creek used to run under here, and we've buried that, some other ravines and creeks. I still, on my bike rides in, can tell from the lay of the land where some of the natural history was when there were still trails that were built and followed by Indigenous peoples. And I still am conscious of that as I ride around the city. Today we have really great lineup of people, but first we want to know, for the people who are participating and joining us today, if you've joined us previously. So we'll load up this poll now, and it's a very simple poll. Make sure everybody knows how to link in. And I see that we have over 125 people here with us today. I get this when the poll pops up, I can see. So very good audience today, and I know we'll have a few more. We're just a few minutes in, and really fantastic to have this opportunity to share with you. And people are very fast. Over 100 people have already participated in this poll. It's fantastic. We try and have a question that everyone can answer off the top of this. So this is just a yes, no. And this is pretty interesting for us, actually. We are getting the word out. And if we can share this poll now, it's always amazing to me that often we have like 30% new, but this time we have 40% that are coming in for the very first time and joining us. So that's fantastic. And I think you are really going to get a good exposure to what the Health System Performance Network has been, because the things we're presenting today is actually quite a bit of our activity and efforts over the past year and in the year ahead. So we're partway into this. So if we could just go to the next slide, I think that we have, I want to put this little plug in, particularly for patients, family caregivers. We're going to know who's out there from this group in a minute. But we have on Thursday of this week, focused for patients, caregivers, and citizens, an event where we are discussing about patient-reported data, patient-reported measurement experiences and outcomes, and how we can engage people in this work, the importance of it, what is really important to you to be reporting on, and then we're going to have a discussion about how it can be reported back. We have some registrants that are not patients, family caregivers. We're letting them in very selectively to make sure that the majority of people attending this. So if you are here and you're a patient, caregiver, or citizen and you haven't signed up and you'd like to have this discussion, please join us on Thursday. It'll be running just slightly after this and a little bit longer. And we are coast to coast. We have people from all across Canada joining in this particular event, supported by the CIHR, the Canadian Institutes for Health Research, and the Ontario Sport Support Unit. And in the latter regard, they are also running an event on April 10th. Now, this is actually more for the researchers, policymakers, so the people, citizens are widely invited here, but everybody is as well. So it's their 10-year milestone research day. There's online registration only. The in-person spots, I understand from Sport Support today that they're filled, but if you wish to join in and you can have a sense about some of the work that's happening from OSU supports many of our trainees at the Health System Performance Network, research trainees, and they do a lot of work on patient-oriented research and also equity. Thank you very much. Today, though, here, we are going to be talking about leading projects for home care and learnings from a realist rapid cycle evaluation. And rapid cycle, I think you might understand, and you'll understand a little bit more about realist in a few minutes as well. I'm here as a host, and the co-lead for the evaluation is Dr. Kayla McKellar. We also have Jessica Morgan, who's doing a lot of our quantitative analysis, and Dr. Guy Ambildania, who's leading a lot of our qualitative work here. So we also have amazing guests today. We are so fortunate. Jon Kwok is joining us from the Nipissing OHT. We have one of the co-chairs, Lindsay Wingham-Smith, from the Integrated Home Care Committee. And we have from Ontario Health also Nisha Singh, Meghan Cunningham, and Janine Theben, who are leading the Ontario Health Team Initiative and are very, very much involved in the leading projects. And we'll have commentary and questions available for you to ask them about being involved in this work. They're very, very closely involved in all of this work, particularly oversight across all of these teams, as well as the initial 12 accelerated Ontario Health teams as it relates to this home care work. So really looking forward to having a conversation with them towards the end after we've done some presentations. Okay, we have one more poll to get a sense of, we certainly have the names, and I see Marjorie was a few minutes late joining, so welcome Marjorie and Fatima. But for now, we want to know a little bit about where you're coming from. Are you actually involved in one of these leading projects? Are you watching closely as an initial 12? Are you generally interested? You're an OHT, but you want to know what's happening. Are you a non-OHT observer, or are you just an interlocutor and here for the ride? And I promise you it will be a good one. It's going to be a lot of fun today. Really fantastic. We're up over 150 people now online who have joined us here today. So I think that it's a great attendance event for us. And I think it's a really timely topic. And I hope that you will, I'm sure you're going to learn a lot today about the projects themselves and about how we are bringing on the teams. Okay, so let's share this out. Actually, there's people from all different groups represented, including some people who are just here for the ride. You will have a great time. But many people who are interested as a non-I-12, that's aware that's many people as Ontario Health Team participants from the 46 teams that are not in that accelerated group. So that's just over a third of our audience. Very close non-OHT observers, and we have about 20% are here actually from the teams that are in leading projects. So for those teams, much of this material you may have already seen because there's nothing here today that we haven't already shared with at least the evaluation groups and the leading groups for the leading projects. Our approach at the Health System Performance Network is that we first work with the people who generate the data through their activity and provide that back to them so that they can make their improvements, changes. We then work with Ontario Health, Ministry of Health, our partners, Ontario Health at Home in this case, to make sure that they are well informed. And then we go out with broader audiences. Okay, I am now going to just give a little bit of a quick overview on the leading projects and our purpose here. So the purpose our purpose is to understand what changes are reliably implemented in the leading projects, in home care, to understand the effects of the leading projects on client, provider, and system outcomes. So it's a comprehensive quadruple aim I'll talk about in a second, and to assess the conditions necessary for scale and spread of successful models. So really understanding the context, and that's the realist part that we're going to bring to this evaluation. We're going to detail more about the specific leading projects a little later. Kaylee's going to talk about them. Right now, I'm going to give you a little bit of an overview to the evaluation approach. So first off, explaining realist, it's this idea of what works for whom and in what context, that if you take something like a leading project for home care and you're trying to innovate, how you do it in Chatham-Kent may be quite different from how you do it in downtown Toronto or East Toronto, where you have a different set of resources. People are in different locations. You have different physicians involved, different hospitals, that kind of context, and understanding that and how people then activate the resources within their own areas. The other bit about this is re-aim. So the idea of, can you reach the people you actually intend to do it? We're measuring effectiveness, adoption. So are people able to adopt the changes that are planned? And then what are some of the issues around the actual implementation? And for those people who have been involved, there have been many fits and starts to the actual implementation of the plans in the leading projects, as many shifting sands happen around this place. It's been very active, dynamic, fun-filled environment for doing implementation and evaluation. And the last bit here is about how do we build and lock the good things in that are happening for maintenance and sustaining the models. That's fine. Go ahead. Thank you. We are doing this from a quintuple aim framework. So anybody who's seen our work before has seen this many times. Patient experience, health outcomes, cost and provider experience. Today, you are going to see a little flavor of every one of these, including how we bring equity into the evaluation on each of these particular aims. And we do this through measurement. And so we are using different forms of measurement. We are using client surveys and system indicators. We have provider surveys, and you're going to see some of that data today. You're going to see the system indicators, and you're going to see total cost and some resource utilization. And then we're going to talk about the context. So we're going to put some of the indicators up front, and then Gaia is going to come in and talk about the context in which all of this is happening. Thank you very much. Next slide. Just wanted to I sort of mentioned this a little bit. So how do we do this work? So working closely with the leading projects, and we have an evaluation working group that we test everything out with, and we do some co-design. I'll highlight one aspect of that later. Sharing with the Integrated Home Care Committee, then moving up to the tripartite leadership, and with Ontario Health, Ministry of Health, and Ontario Health at Home, and then sharing with this community, and then broadly, the implementation supports community is another group that we share with, and just many, many other groups that we can get out and share what's happening, how people are doing it, and what we're learning. All of this, when we think of evaluation, we think learning. We don't think evaluation as judgment. We think of evaluation as learning. And so this is a great opportunity in how we do that. I think I'm just going to provide this broad overview. I've alluded, we're going to talk about how we're approaching leading projects evaluation. What are the leading projects? Kaylee's going to talk about those. And then how are we measuring quantitative changes using health system indicators? How are we measuring client and caregiver experience? We don't have data, but I'll talk about how. And then provider experience, and then qualitatively, what are we learning? And then we have reflections from leading projects and Ontario Health. So that's how we're going to get through today. And I'll turn it now over to Dr. McKellar. Kaylee.
Hi, thanks, Walter. Oh, can we see me? Hi, everyone. So I'll just start off by sort of extending a little bit on Walter said and going over some of the methods and approaches. So again, we're undertaking this work in partnership, so co-designing with leading projects. For example, the measures that we'll talk about later, we initially started by looking at the leading project logic models. Again, we're interested in supporting learning and development, and that's for the leading projects as well as system stakeholders. And again, looking at the future of other OH3s interested in this work. And again, looking at being flexible, engaging, and interactive, and adapting to local context and stakeholder interests. So on the next slide, is an overview of our methods. So we can see at the top in dark blue are those sort of overarching evaluation questions that Walter reviewed. And then we also have another subset that are secondary or have been added in as interests have come in. And those are what changes are planned, and that's really informed our early work. What factors help or hinder program success? What conditions enable successful care coordination? And what is the comparative effectiveness of the leading projects? And on the next slide, I just highlight what today's focus is. So we'll start off with what changes are planned, and then move into what are the effects of the leading projects, which we can't actually answer right now, given that they've just launched, but we're going to walk through how we're setting up our evaluation to understand this, as well as what are some of the baseline results that we're seeing related to these indicators. And then finally, looking at factors that help or hinder success, which Gaia will share. So on the next slide, or 2 slides, I'll just provide a little bit of the leading projects. So what are they? So 7 Ontario health teams are leading the leading projects, and they've been launched to model innovations in integrated home care services within OHTs. And there are 2 overarching objectives. One is that's to test and evaluate OHT-led home care models that improve care integration, access, patient outcomes and experience, and also to build OHT capacity for home care planning, delivery, and integration. So 2 high-level goals there. On the next slide, we have an overview of the 7 leading projects. So there's a lot here, but I'll just say that they're grouped right now into and color-coded by model type. So we have in blue this sort of neighborhood models that focus on centralizing services in the neighborhoods. In pink, primary care, so that having a focus on embedding designated care coordinators and home care providers in each practice. Palliative in yellow, which is about sort of early identification of palliative care patients and their needs, and community crisis, which focuses on the sort of high-risk need patients. There's also some differences in terms of how the implementation sites for the leading projects. So some are at the neighborhood level or practice site. They also have different scales in terms of the number of patients they are going to serve, and of course, a unique aim. And I'll actually skip over the next slide, but this does sort of highlight those key pieces. But I want to look at this. Now, this is quite a busy slide, but I just want to get it to the key points here that there's a lot of diversity in each of these leading projects, but there are some core structural elements that are the same. So for example, looking at the bottom, you have payment models and changing fee for service to a capitated rate, or IT platform and digital tools and improving those for communication. So we have some sort of core changes that we're seeing across the leading projects. There's other changes that are central to their model type, for example, sort of the embedding within a primary care practice site. And then there's other changes that are happening, or parts of the models that happen based on the context or the plan. So for example, client or community education, where some are doing it and others are not. So that is a very quick and dirty overview of the leading projects. And with that, I think I'll pass it to Jessica.
Hi, are you able to hear me?
We can now hear you.
Perfect.
Come on camera too.
I'm on, oh, there we go.
Lovely, welcome.
So I'll be sharing the quantitative indicator results at baseline. So where the focus populations are at for each of the leading projects prior to implementation. We anonymize the results, so you won't be able to identify the leading project, but it's really just to share how we're evaluating and sharing back this information with each of the teams. So individuals were included in this baseline if they were enrolled in home care and received home care services in the fiscal year of 2022-23. And specific program criteria were applied to the definitions for the baseline comparator populations. So some leading projects selected based on geography, whether the patients were palliative or not, their affiliation with primary care teams, or other criteria. And with respect to the palliative care populations, these were included or excluded based on a comprehensive definition, which extended beyond home care as these programs are expected to expand beyond expand the home care-based palliative care to new patient populations. So next slide. So here we have the list of the agreed to quantitative indicators. So the cross-project indicators were agreed to by all leading projects as core measures, which are applicable to all the programs. And these were selected in an open discussion with transparent selection and voting on indicators. We also have 4 indicators specific to palliative programs as well. Next slide. So again, we're following the quintuple aim framework to evaluate these programs. And the quantitative piece of this work looks at some of the measures of patient health outcomes, the health system utilization, as well as costs. And we will also show some of the process-oriented measures that inform our understanding of what these programs are actually implementing. In terms of who is included in this baseline, the majority of clients are older, so the average age is 76, with 25% being over the age of 86. Most clients are female, and the largest proportion are living in neighborhoods with low access to material resources. So in this presentation, where I refer to material resources, this is the new name of the dimension of the Ontario Marginalization Index, which was previously called material deprivation. So you may be more familiar with that. So this is an area-based measure where people in quintile 1 would be living in areas with the most access to material resources, and those living in, or those in Q5 would be living in areas with the least access to material resources, so the highest material deprivation. And here we can see that there's a tendency towards, low SES or high material deprivation. Next slide. So here we have the program activity measures, so service time per client month, as well as the proportion of service volume by type. Each of the bars on the graphs represents a different leading project. And I'll just say that when we're evaluating, we're not necessarily comparing between the different projects because they do have different objectives and populations, but we're presenting it this way just to show that there is variation in the projects. So here, this really does show the variation in services as well as the proportion by different service groups. And these are just informational items without specific targets at this moment. And they can help contextualize the results of some of the other indicators we have, such as costs. So next slide. So this is the caregiver distress indicator, and it's a measure of caregiver experience. And this data is pulled from the RAI assessment data, but we also have other survey measures of client and caregiver experience. And we also have later in the presentation, patient measure of care and how easy it is to access care as an important patient experience measure. So we can see that the caregiver distress across projects varies from a lot of distress, so 37, or far too high rates of caregiver distress, so 76% of clients who report that their primary caregiver experienced distress. We also looked at caregiver distress through an equity lens, so that will be on the next slide. And here we can see differences across sex. So this is actually the sex of the client and not the caregiver. So caregivers of male clients are more commonly reporting distress. And we also see differences across access to material resources, but in this context, it actually doesn't indicate inequity because we can see that areas with higher access to material resources are the ones reporting distress more frequently. And this could be due to several factors. I will point out again that it's an area-based measure, so it may not reflect the individuals living in the area accurately. And at this point, we also have not standardized these results. So just to interpret with caution. The next indicator is the wait time from referral to service. So this is an indicator of access or experience with care. There is a fair bit of variability across programs in terms of wait time length. but most fall within that 10 to 15-day range. But this is one of the measures that we are hoping to see some improvement on post-implementation for the projects. So next slide. It's also another measure that we looked at through an equity lens. And in this case, we see again some differences by sex, but in this case, not by material resources. So change in health status, this is an outcome measure. And we saw that over time, the health status of long stay home care clients declined. And we're hoping that with the programs, they are able to slow the functional decline of clients over time. So this baseline measure will help us evaluate whether that is going to take place. Next slide. So ED visits for conditions best managed elsewhere, as well as unplanned hospitalizations. These are both utilization measures, but also proxy measures for access to care and health outcomes. And again, we do see variation in these indicators across the leading projects. And these are also two indicators which we took an equity approach to. Next slide. So again, for ED visits, conditions best managed elsewhere, we saw that difference in the sex of the client, but we did not see a difference in access to material resources. And this was also the case for unplanned hospitalizations. Next slide. Next slide. So as I mentioned before, there are also 4 measures which were specific to the palliative programs. So the first 2, which are ED visits in the last 30 days of life and the palliative home care visits in the last 90 days of life, these relate to access and outcomes. So the thought is that by providing more home care to clients in the last 90 days of life, the programs will be able to reduce the use of the ED in the last 30 days of life, as well as reduce overall utilization in the last 180 days of life. So if we go to the next slide, we can see that measure. So we're hoping that to improve on the amount of time spent at home in the last 6 months of life, and also hoping that clients will be more likely to die in the location of their choice and less likely to die in a hospital. So deaths in hospital is that proxy for death in location of choice. Next slide. So lastly, we have costs, and this is an essential element of the quintuple aim. So here we are reporting on the monthly spending per client broken down by home care costs and other health system costs. And we will be keeping a record or reporting on this on a lagged quarterly basis. And this is another indicator where you see that variation by program, and more specifically, we see higher costs in programs where there are more hospitalizations. So that's it for the quantitative indicator piece. So I'll pass it off to Dr. Walter Wodges.
I'm just shifting it along, I think, is coming back to Kaylee. So I think for the next little bit, so we can move on to the next bit on provider experience.
Yeah, I'm happy to share the interim provider experience results. So for the provider experience, we use to understand that, we use the HSPN provider experience survey and tweaked it a bit for the leading practice population. This survey tool is available on our website, and we've actually had webinars previously that have focused on it. So we distributed this between November of last year and February this year. The distribution lists were provided by the leading projects, and they do differ again with the different characteristics of the leading projects of who would be included in this. We had an overall response rate of 38%, which is great. And just to highlight, the survey domains that we asked about were care coordination, workplace culture, autonomy, digital and virtual care, burnout and satisfaction, and demographics. And I'll provide just some highlights on care coordination, burnout, and demographics for this webinar. So quickly, in terms of demographics, you can see that the majority of the respondents were women with some variation across leading project. In terms of ethnicity, we also saw some variation across leading projects, and I'll just highlight in terms of other that wasn't a response option, but given our rules to not share responses with 5 or less to protect anonymity, we had to group some of the ethnicities together. On the next slide, it shows some information about the roles of people who responded to the survey. So you can again see some variation by leading project. And this again has to do with the characteristics of the context of who is participating in these leading projects. And this also sort of shapes the responses to the questions as well. On the right, we see the overall number of respondents from the different role categories. So a pretty reasonable representation across. On the next slide, we get into the results. So starting with care coordination. So the question on the left there is, how often do you know about all the visits your patient or clients make to other healthcare providers? So I'll orient you a little bit to that figure. We have on the top, we have the positive responses or always. On the bottom, the more negative responses. In red, we have never. The black dots represent sort of the average or mean response for each of the leading project, and the bar across is the overall average. So here we can see that sort of rarely is the more common response, and there's some room for improvement there. On the right, we have how often do you receive timely and accurate information that you need to deliver care from other providers. So here we can see a slightly more positive response overall, with sometimes being the more common response. On the next slide, so here we have, when clinically appropriate, how often is it easy to obtain a curbside consult from peers or other providers in lieu of providing services? So here, while the average is similar to the last one, we see more variation where people are more likely to report the extremes, such as always or never, and a bit more variation across the leading projects. Our next piece, how often is patient care well coordinated with community resources? So a really important indicator to consider for integration. And again, we have sometimes as the more common response, but there's room for improvement here with about sort of 45 to 20% reporting often or better. On the next slide, we have burnout. So for this indicator, it's using your own definition of burnout, which statement best describes your situation at work. So here again, the blue is the positive responses of I enjoy my work. In red, it's sort of a more negative response in terms of I'm feeling completely burnt out and often wonder if I can go on. So not a good situation there. You can see there is quite a bit of variation across the leading project and definitely some room for improvement as well. I want to highlight as well that while this shows an area that we hope to make improvements on, it also represents sort of a contextual challenge for the leading projects, right? Because they're working on sort of this integrative system work, and that can be a challenge for people when you feel it's sort of your house is on fire. So next we have, we're going to look at some of these in an equity lens, so looking at the different responses by gender, ethnicity, and role. So in terms of receiving timely and accurate information, again, this is important for that relational coordination piece. We see men are slightly more likely to have a more positive response to this. For easy to obtain a curbside consult, we're also seeing that pattern, but to a lesser extent. For burnout by gender, here we can see that it's more common for men to report symptoms of burnout than women, but not a drastically different response pattern. On the next slide, going back to care coordination, so looking at the same indicators, now this time by ethnicity. So how often do you receive timely and accurate information? So again, a fairly stable response, but we're seeing those grouped into others are more likely to have sort of report the always or often responses. For the curbside consult, again, we're seeing some variation with those grouped into others as being more likely to report never, and sort of more negative responses for those identifying as white. In the next slide, now looking at burnout, so this by ethnicity. So there's a somewhat lower reporting of burnout symptoms in the Asian population. And then those grouped in others, we're also seeing a higher variation. So those more likely to report both enjoying their work and being completely burnt out. So seeing some differences there. Then looking finally at care coordination, again, by role. So we have on the left, receiving timely and accurate information. And this is actually relatively stable across the roles. But we do see sort of support workers as being more likely to report both positive and negative. And then in terms of obtaining a curbside consult, we do here see a little bit more diversity in responses, with nurses having a slightly more positive response, and social work where there's more room for improvement. And finally, on the next slide, looking at burnout and satisfaction by role, again, we're seeing some diversity in responses, with physicians, nurses, and care coordination being more likely, care coordinators, sorry, being more likely to report burnout, and care coordination having no more room for improvement.
Fantastic, Kaylee. That was a lot of info, and people getting a real sense of what things are looking like at the very beginning of these programs as we look to expand and understand. And I've really great kudos to the teams. Talking about provider experience is one thing, actually going out and measuring it is another. And it takes a fair bit of negotiation and I think discussions on being able to do that well. Also support from Ontario Health at Home and being able to do this with care coordinators, even before being assigned to these roles necessarily or starting these programs. Again, an openness to doing this, and that takes courage. And I just appreciate that. And I think we're all in a really good position as a result of this to be able to do this and actually be able to do quintuple aim. As you see, we're also looking across different stratifications for that. Here, I'm going to talk about patient and client experience and caregiver experience. We're leveraging existing surveys. We don't have the data here for you today. We have we're going to be collecting some of it ourselves, but on the baseline, we're going to be relying on a data feed from Ontario Health at Home, which has been agreed to. So I'm just going to talk a tiny bit about how we measured it. So I want people to be aware that HSPN, and actually it was HSPRN in the day, about 7 years ago, did a very thorough review of home and client and caregiver experience, and we built a new tool for the home care experience. And actually the tool that is being used now by Ontario Health at Home is the tool that we built. And then we will also be using the Voices Caregiver Survey for palliative. And then I'll talk for a moment about priority measures. But if we go 2 slides ahead, we'll see how we had built this new tool. That QR code, there's a link at the bottom of this page to where you can find out. There are actually 7 reports attached to the development of this tool. And you can get to, there's a whole space in our web space about this. So first off, many of you have seen Dr. Goluski's framework around what's most important to clients and caregivers. That work informed all of our work in patient and caregiver experience because it was built on over 175 qualitative 1-hour interviews with clients and caregivers in 3 different jurisdictions and 9 different programs. We also did at the time a jurisdictional and literature review to stay up to date about how other jurisdictions were doing this kind of measurement. And we reviewed extensively the existing tool and particularly the open-ended and qualitative comments that were coming in, which really was very informative to us as to what was not in the existing tool and what some of those issues might be. So we did this, we came up with domains and sample items. We had many engagement sessions with clients, family caregivers in Ontario, as well as a leadership and a steering committee to review. We built a pilot instrument. We did cognitive testing and a field test in 3 at the time LINs to develop the new tool that's being used now in the field. So quite a bit of rigorous development on this. Some of the content on the next page, just to get a bit of a sense of what's in there, is there's like, as you start home care, the planning home care, as you're receiving care, the right types, enough. These were questions that people thought were important to them. And the whole point of this tool was to actually say, what is important to you as you receive home care? Communication was very important, many items around there. And then about the providers themselves, they're treating you courtesy and respect, being involved, do they have the necessary skills? These were really things that were important. And then overall experience items. So you get a bit of a sense of what's in that tool. And we'll be using this as the baseline because it's been collected now for the period prior. And then as we go forward with the clients themselves in the new program. So I think we're going to have a really good sense. For the palliative program, we'll be using the Voices palliative care survey. And the key themes that are lying underneath this, you can go check out the link here for more information about this tool, is around meeting care needs, understanding if people received care in a hospital, what that was like, what it's like in the community. It's mostly oriented to community, but it does ask questions if people received hospice, for example. Communication, support for relatives, and dignity and respect. Again, they're actually fairly similar themes as to what we have in the other tool, but this is actually asked of caregivers 6 to 10 weeks after people have passed away. So we will have that data, and that's what we're using for the last quadrant of the quintuple aim. So that's our set of indicators. Oh, and this is just an example of how we chose what measures we do. So this is from a Mentimeter that I actually took from a screenshot from one of our meetings we had with the leading projects. We have 5 items here. This one is actually out of, we did this for many of the indicators, but this was out of the client experience tool, because you could see it was a long tool. So we wanted to know which are the few indicators and the few measures that we should be. And so we actually did this kind of a rating and had people who were participating in the programs choose the indicators that were most important to the leading projects. And so that's how we came to consensus across all 7 programs. Everybody participated in this engagement around the identification of measures. They were not brought in or set out by the ministry or by Ontario Health or Ontario Health at Home or us. We were facilitated the selection of the measures by the teams. So I think that's a sign of reasonably positive engagement, and also makes the teams more interested in the evaluation and making it a little more formative. So that's it about indicators for us. And now we are going to hear from Dr. Mbuldania, and she has very insightful knowledge that has come from dozens of interviews across the many programs. Gaia might highlight a little bit of how many there have been, because it's not just Gaia doing this work, it's others as well supporting it, but under Gaia's leadership. But I'll turn it over now, Gaia, for you to summarize one part of the qualitative knowledge. Thank you.
Thank you, Dr. Watches. Okay, so perhaps yes. So the question driving this work was just, what are the facilitators and challenges experienced by the home care leading projects as they plan for implementation? Next slide. Okay, so this is the basket of methods that we used for this work. So we started with a document review, so reviewing funding applications, the logic models, and so on of the programs, just to understand what these programs were aiming to accomplish. And we decided to do a deep dive into 3 teams with monthly observations of key planning meetings and interviews scheduled twice over the evaluation period. We've essentially finished with one of these, the pre-implementation phase, and that's what we're going to be reporting on today. We're doing focus groups with the other 4 that sort of coincide with the timing of the interviews. We're also doing reflective check-ins with all the teams. So these were monthly at first, and now quarterly, given more established pace of the projects. So about 45 participant voices are going to be featured here, well, in synthesized form, but across the leading projects. And these are the voices that really contributed to the results that you're going to see. Next slide. All right. So these are the key themes that emerged. So implementation facilitators and challenges included planned levers of change, and Kaylee took you through some of these at the beginning. In relationship building, leadership, building on testing and managing change, flexibility and tailoring of the model, physician engagement, risk and uncertainty, and commitment and motivation to integration. So these are really both facilitators and challenges, as you can imagine, except perhaps for risk and uncertainty. That's more obviously a challenge, and the planned levers of change we hope will, be just a facilitator. So obviously, the presence of many of these things, take relationship building, for instance, its presence was a facilitator, its absence a challenge, right? And they showed up in some form to some degree in a majority of teams. They're not immutable, so what might be first experienced as a challenge could obviously be resolved over time, mitigated over time, and then maybe even turn into a strength. And they cannot really be understood in isolation from each other. So relationship building, for instance, may be contingent on other things, maybe robust leadership, which then might help you navigate uncertain policy environments or whatever it is, and so on. Okay, next slide. So relationship building. So I'm just going to pick about 4 or 5 of these themes, but I think you'll see glimmers, shades of the others sort of coming through as well. This slide focuses on partners, and the next slide, relationship building happening as it relates to providers, because obviously relationship building happens at these different levels. So it won't come as any surprise to know that mature partner relationships correlated with a shared vision. So here's a hospital leader saying, whenever we, the hospital, ask you at CCSS, obviously this was collected before it turned into Oh Wretched Home. Whenever we ask you to take something on, you start from yes, and then you figure out how to do it. I think that's a bit unusual as far as a relationship between hospital and home care is concerned. And an HCCSS leader from the same team saying, when you come to an in-person collaborative meeting for our OHT, it's like a party. It really is a unique experience. However, there were certain limits to sharing and collaboration that were experienced by a number of teams as well, right? So here's a leader saying, is Oh Wretched Home truly a willing and contributory partner to these projects? They still hold a lot of power and sway over the outcome of the project. And we see hesitation in how much buy-in we're getting. HSPs haven't done this before. I feel like they've asked us, do you accept the set of services that we're offering? And our response is, yeah. That looks pretty good, but we don't know what we don't know. That just feels like an example of Oh Wretched Home saying, sure, we'll do this. We'll do exactly what we're asked to do. Well, it would have felt a bit more collaborative for there to actually be a conversation between the HSP and Oh Wretched Home to help them understand what's required to run home care. So 2 very different types of relationships, as you can see, with the same organizational partner, albeit with different people at the local level. And unfortunately, the experience on the left was a bit more unique. Okay, next slide. So building on testing and managing change. So building on existing innovations that leading projects knew were working well. This was something many projects did, and it helped because it provided them with a sense of confidence. And test running planned innovations was also helpful. It was something I think one team was able to do really well. Others were able to do certain aspects of planned innovations, and doing so really helped identify gaps. So you had, for instance, a community leader realizing, what, the care coordinator is giving one message, and we, the partner service provider, were giving a completely different message. Or the realization that physicians were being contacted a lot. And this allowed for solutions to be developed, even in this pre-implementation phase, right? So coordinators, perhaps they decided could call physicians' offices and have the receptionist triage questions. Mentorship could perhaps be provided by an experienced navigator who could accompany not as experienced care coordinators, perhaps to visits in tandem with clients. Okay, change management sessions helped a lot. As well, they provided an opportunity to introduce the project and communicate changes. It allowed providers from different organizations to meet, to begin team building, to ask questions, voice concerns, provide input into plans, and so on. So here's an administrator, hospital administrator saying, well, change is hard because there's so much ambiguity, but to be uncertain together and to ask the questions in one space and receive that training, well, I can see the benefits of that. Next slide. All right, so flexibility and tailoring of the model. So being able to test changes to care delivery on the ground really helped. It allowed teams to flexibly tailor their model, whether it is, tailoring it by site or whatever it was, right? And the lack of flexibility really came in the way of relationship building and this development of a shared vision. So here's an OHT leader saying, if we're thinking about this as the Thanksgiving dinner table, well, HCCS is at the table, but limited in their ability to eat the turkey, constrained by, I think, a culture of risk avoidance, constrained by a directive to standardize provincially, despite there being 58 OHTs and 7 leading practices that are by design supposed to be different from each other. And this obviously would have an impact on this relationship building piece. However, you know, an experienced leader, and you see this leadership theme coming across here, they might be able to creatively negotiate a tension between innovation and harmonization. So you're releasing this tension between the need for flexibility, which is a boon, and yet this impetus to standardize, which has its own benefits. So here's an HCCSS leader saying, across our organization at CCSS, we're being told to adopt a consistent approach so that all 7 of our home and community care programs are approaching this in the same way. So for example, we would do a light touch eligibility and determination of what the patient actually needs, and then send it over to the leading project. And I'm not sure that works for every population. I'm trying to find areas where there's wiggle room, find ways to influence things from a home and community care perspective, but still fit within the rules. Next slide. Risk, uncertainty, and commitment. This is really the fusion of 2 different themes. So risk and uncertainty being one, and commitment to the model being a second one, you know, despite this atmosphere of risk and uncertainty. So risk and uncertainty came in the form of, for example, delays, which put relationships at risk and frustrated momentum. So here's a HCCSS leader saying the service providers, used to show up faithfully. Like 2 summers ago, they were at every meeting. We'd get people from their head office here, but now it's been crickets. We can't even get them to attend locally because they've moved on to other priorities, because this is delay. And then, so the SBO procurement process and engagement timeline, this also contributed to the sense of certainty. Because, you know, some teams were actually trying to leverage their SBO's knowledge and insights for the leading project innovation itself. And their SBO was a key partner, right? They'd be at partnership meetings and so on. But now they couldn't talk to them because of this procurement process that was ongoing. And there was also a good possibility that their existing SBO might not actually be the one that was selected in the end. So here's a leading project leader saying, we have been feverishly working with our newly announced SBO. So this is a team that ended up with a new SBO partner to figure out privacy agreements, digital solutions. So we're only now getting to what is the transitional lead going to do? What is the care coordinator going to do? But because of that blackout period, we could not advance any of these conversations. We didn't know how well versed our SBO partner was going to be. I understand the RFP and procurement rules, but just the way that the timing fell, it's an unfortunate situation. So despite this, you did, however, see many leading projects really articulate this commitment they felt to this transformative vision that the leading projects represented. So here's a HCCSS leader saying, we're working as though the project's already been funded, and it's not. So you don't do that unless you have significant trust among the partners. So if the hospital doesn't approve it at their board meeting tonight, the leading project partners have said, well, we're going to move forward with it anyway. It just means that we may have to adjust a bit, that maybe we won't be knee deep in it, we'll just be shin deep in it. Okay. Next slide. Okay, so in conclusion, this is just trying to articulate a vision for the future. So a number of the themes that you're seeing here really center around this idea of rules, so whether it's you know, protocols around standardization or the SBO selection process or whatever it is. And there's this underlying concern that that rules that would distance from the local context don't perhaps make sense either for providers, as you see in this first quote on the left, or for patients, as you see in the second quote. Okay, so first you have a hospital leader saying home care modernization is removing some of the rules-based thinking that care coordinators are just authorizers of service, that this can't be funded or this can't be provided because it doesn't fit in our rule-based system. It is one of the things we are unfettered by in our hospital-run home care program for the most part. when the team sometimes sheepishly comes to me and says, in order to get this person home, we need to get them a mattress. So we went and bought a mattress from Sleep Country and had it delivered. Is that okay? I'm like, yeah, that's okay, because at least they can say they would have stayed 5 more days in hospital at $1,000 a day versus the $133 you've spent on a mattress. And the outcome of rules-based thinking is not person-centered care. And on the right here, you have a PFAT member talking about the care her mum is receiving. So she says, I have workers from the SBO here sitting with my mother, listening to music, doing this and the other thing while I run around cleaning, doing her laundry, putting in the orders for her supplies, and on and on. And I think, shouldn't I be the one sitting with my mom? Shouldn't somebody else be doing these other things? And they, the PSWs, are very, very limited in what they can do. Once I had made the PSW a cup of tea, as it puts you in a better mood for caring for my mother. And as she left, she says, oh, I put my cup in the kitchen for you. Okay, but there are things that they're not allowed to do that I kind of shake my head over. It doesn't cost any more money. It's a better use of the worker's time, but we don't touch that. We're looking at the structure. Should it be this agency or that agency who's in charge of home care? So essentially, leading projects were saying, in order to truly transform home care in a meaningful way, changes need to be made that sort of go beyond the bureaucratic structures, right? So changes that are perhaps a bit more ambitious than what was originally envisaged. Okay, next slide. So moving on to recommendations. So this one is directed at OHT stakeholders, and the next two will be directed at system stakeholders. So, perhaps signal upfront to on-the-ground providers that their patience and buy-in will be required to identify and work through early implementation challenges, so that they are aware that the partnership, so that their partnership will be required for eventual seamless patient and provider experience. So this hopefully, for instance, will preempt physicians trying to engage in gatekeeping and discouraging colleagues from joining the program until all the wrinkles are ironed out. Then have open conversations to understand the scope for and benefits of both a tailored and standardized approach in different contexts. And this recommendation really emerged because of this connect we were noticing between OH at Home and the leading projects, with OH at Home really pushing for standardization because that's what they had been tasked with doing, and leading projects pushing back because they thought the whole point of this exercise was to try different approaches, and a one-size-fits-all approach suddenly, didn't seem like it would work for them. Okay, then unexpected SBO changes will require attention to developing new trusting relationships. That was not part of original plans, perhaps, but this may require additional work and time, but it's important given the evidence that trust really is a key enabler. Next slide. So moving on to recommendations for system stakeholders. So just, I guess, start off being aware that many OHT stakeholders thought that the leading projects did not necessarily address key issues pertinent to either patients or providers, whether it's PSW roles or privacy regulations. And then also be aware that project delays and the lack of directional consistency and dependable funding really frustrated OHT's ability to engage stakeholders and hindered understanding of long-term vision. So when we presented these recommendations, recently back to the leading projects, it was this lack of directional inconsistency that they really honed in on. So we did have it in the background of our recommendations, but we sort of brought it to foreground because they really flagged it for us. Okay, and then flag expected outcomes in relation to timelines. So what is expected in the short, medium, and long term, and hopefully doing this will mitigate OHT anxieties by acknowledging that certain impacts may take time while providing a realistic roadmap of direction and accountability. Next slide. Okay, so the tense relationship between many OHTs and OH at Home needs to be addressed for meaningful collaboration going forward. So just some ideas here. Is there scope for working on timely responses to requests given interdependencies? Is there scope for getting all stakeholders on the same page about the legal framework within which OH at Home operates to mitigate finger pointing? Is there scope for collaborative guidance provided to leading projects and HSPs to help them understand the intricacies of what is involved in delivering home care? And you might have other ideas, and please feel free to pop them in the chat. Okay, next slide. Okay, I think that's it for this bit of things. I think we'll have a good amount of time for questions. Back to you, Walter.
Oh, great. Thank you very much. Really appreciate Gaia coming down, and we have had a couple more comments and suggestions in here that I think are also very, very good leading into some of our discussion and opportunities. I encourage people who are online to continue to share your thoughts and your suggestions. And I actually saw a little bit of group chatting back and forth around some of the indicators, particularly around the burnout and some of the other provider experience that generated some group discussions. And I think hearing those are really, really a fantastic opportunity. I'm going to invite, we're actually running pretty good on time now. We had a lot of material and a lot of slides, so I was a little anxious. So we might have gone a little quickly at times. So I'm going to continue to look to the chat a little bit, but I'm going to invite Jon Kwok, who's here from Nipissing. We had a few others, but they had operational issues as they're going to the field right now and challenges and in joining us today. But I appreciate Jon very much coming on today from the Nipissing Ontario Health team, and yours is I'll describe it as transitional hospital to home type program, but you might actually provide like just one sentence or two about that program. And I know you're picking up really high risk people. And my question to you, Jon, I think is around these, as you reflect on these findings, what do you think, the opportunity for your program in Nipissing and maybe in general for the leading projects to have? What kind of impact do you think these leading projects are going to be able to have?
Thanks, Walter. Yeah, so first of all, my name is Jon Kwok. I fill the role of Project and Quality Lead at Nipissing Wellness OHT. Our model does involve hospital. I wouldn't quite call it hospital to home, but it is similar. We do have a separate H2H model as well. But yes, we try and pull patients both from hospital and community, those who are crisis and high risk, and try and support them on the pathway to long-term care. So actually, we've recently, we'll say, renamed or dubbed the program just because Leading Project didn't really have the same kind of oomph with the patients. So we're calling it Home to Long-Term Care. So yeah, that's how we would describe our model. In terms of impact, I do have a few thoughts. I'll try and kind of keep them connected here. But so first of all, from kind of a broad provincial lens, the first 1.5 to 2 years of this project were spent really supporting discussions, engagements, and overall planning of the common elements across the group of 7 leading projects. So there's that opportunity for a kind of province-wide collaboration. I see this as a great opportunity for the OHTs to have a say towards the future of home care. From there, the more recent months have been focused on kind of transitioning to implementation. So you've heard today a couple of times how projects have gone live, and we're all at different stages of that. But as we move towards that, the conversation's really moved more to a local focus. So I don't really want to speak on behalf of the other leading projects, but I will speak to kind of Nipissing. So we saw an opportunity, a strong opportunity to shape a model that really meets our local needs. So a truly integrated model where maybe we'll call it the traditional primary players like OH at Home, acute care, even the service provider organizations, they're still leading the way, but very much being informed by and consulting other partners in the region, primary care, community support services, and yes, patient family caregivers. So all working together. So I'll give you a specific example. So kind of not prior to the project, but kind of throughout, we heard that there were situations where care providers from different organizations didn't always have awareness of how each other was supporting a specific patient. So for instance, PSW from one team might arrive at the same time as an OT from another team, and there just wasn't that communication. So our hope is through coordinated care planning, care conferences, even digital collaborative tools to improve that communication and collaboration to improve quality of care for the patient. So that's kind of broad, and then moving more closely. But having said all of that, tying in today's topic a little bit more, hoping that the evaluation and the data points combined with the subjective and experiential lessons learned hoping that they provide more information that can be used in the development of an overall home care roadmap.
Yeah, that's fantastic. And I really think a couple of points that you've made there. First off is the input of these projects to the future design of home care in the province. I think that's just a massive value add. And I think we're into many of the areas across the projects of embedding coordinators and home care more closely into primary care and a few of the models, and then neighborhood models being another tested model, because I think a lot of home care is place-based. It takes place in people's homes. So thinking about those approaches, and I think that your allusion as to how we can better connect and actually how we even change the procurement approaches to home care so that it can be more aligned and encourage easier communication across providers is a real opportunity for showing what works, learning what we have to continue to improve on, and then using that to inform. And I'll be calling on our OH colleagues in a moment, and how they're thinking about how we can use this. And they're not the only people involved in setting the policy going ahead, for sure, but they do have a role to play. Use it to inform the new models of care going forward. And thank you also for highlighting the sort of crisis, really high acuity needs a population that your program is focused on, right? Like those people who are really at risk for all kinds of things, and requiring a lot of care from many different elements of the health system, right? Hospital might be necessary at certain points for these people, but primary care specialists, home care, there's a lot of people coming that are needed, even social services, I presume, community supports to enable those people to be maintained at home as long as it's safely possible, right? Like I think there's always these thresholds and better. So so we might come back to you. The audience might have some questions for you. There are some general questions, I think, coming in around patient engagement in the models and the extent to which patients, so maybe we'll come back, you might think about that for a moment, if there's a role for how you have engaged patients. I see some questions, but I do want to make sure we engage a little bit with some of our colleagues from Ontario Health as well, so don't go too far away, John. But we have Lindsay Wingham-Smith, and actually Lindsay is also as co-chair of the Implementation Integrated Home Care Committee, is also one of the a lead for one of the Ontario Health teams involved in this program, and has a lot of experience from the Mississauga Ontario Health team. And then we also have Meghan Cunningham and Janine. Hopefully Janine's joined us. I know that she was coming in, and Nisha Singh. So we could maybe have you folks join us now. And I didn't actually go check the room. I'm sure you didn't. I hope you didn't all run away on me. In the meantime, you were all here before.
We're here, Walter.
Here at the beginning. And we didn't scare you off. Hey, Janine and Megan, thank you very much. Welcome back. And Nisha, great, fantastic. And so, I might think about, maybe you have a response actually to John's comment first, and then I might have about, how these projects might potentially be able to inform future design in programs, just from your perspective. You're not, not being holden to Ontario Health. You don't speak for Matt at this moment in time, because you've been very involved.
Yeah, you're right, Walter. We don't, but I think it's a great question. And you just made a comment a couple of minutes ago about kind of a nuance about policy direction as well. So I'll just kind of qualify this to say that from an OH perspective, obviously, we also don't set provincial policy, and we leave that to our ministry colleagues. But I think both from within the ministry, our colleagues at Ontario Health at Home, and within Ontario Health, there's been keen interest in watching and participating along with the OHTs in the planning work, the early implementation work, and the troubleshooting that has happened along the way in really a joint manner, because the lessons learned have been rich, I would say, even over these 2.5 years, coming up on 3 years of planning work, and then really exciting to be at the stage where we have all 7 launched and we start to kind of shift into implementation mode and some of the lessons learned within the operational space. I'll say generally, and some of this has been communicated quite broadly via the ministry as they announced some of the work to modernize home care that OH is involved in. There's several opportunities, very practical opportunities that the home care leading projects will help to inform when it comes to that broad home care modernization work. So a couple of them relate to the standardization of SPO contracts going forward, and I know Janine has been living and breathing with the OHTs a lot of the procurement work, so definitely we'll hand to her in a minute or two to comment on that and with a little bit more specificity. But a lot of learning that has gone into the behind the scenes work on procurement, and then the maintenance kind of operation under a unique capitation model for the SPOs. So lots to learn there that I think we are looking at provincially as we look at transforming SPO contracts for the future. You spoke a lot, and I know Jon commented specifically on the local delivery models that each team is putting into place. While there is certainly nuance from team to team in terms of the populations that they're focusing on and the models of care that they're enacting, there's a lot that can be done through and learned through the evaluation work that HSPN is leading that can translate to some work to inform future standardized outcomes and quality expectations for teams. So again, a lot that will be, I think, pulled from leading projects to inform that work provincially. We know that there is a standardized assignment model for care coordinators that has been worked up in order to stand up these projects, and a lot of the stuff that is less kind of interesting to talk about on screen, but it's like super important operationally is, you know, the development of job descriptions and workflows and, you know, standard service offerings. None of this can happen in an environment with like that we're working in within the system without standing up all of that. So just again, a huge kudos to the 7 teams who have kind of lived and breathed the development of all of those, I'll call it like the infrastructure behind kind of the clinical implementation that's now happening on the ground. And again, all of those learnings will be transferable to modernization work as it continues. And then the last comment that I'll make is right now, we didn't get into a huge amount of detail on this, but right now the projects have launched in an interim state. They are not operating within the CRIS system for a number of reasons, and it's only temporary. We'll be transitioning back to the CRIS system, we anticipate in the summer. And so again, I think a lot of learnings that can be kind of derived from the work of the leading projects to inform how, you know, this might work in future for other home care programs that might operate within the CRIS system as well, like hospital to home and others. So a lot of information I think that will be pulled upon to inform future provincial efforts. And just again, a huge kudos to the teams for kind of slogging through the learnings. Going first is always a challenging assignment, and we're so grateful for them for their tenacity and resilience as we've kind of gone through the last few years.
Yeah, you raised so many good points there, Megan. And yes, we resubmitted an amendment to our research ethics around the changes in the data flows yesterday as a result of that interim. And digital health is really, I think, a fantastic opportunity in this space. And many of the teams are actually using new digital applications. And it's not a central focus of the overall evaluation, but I think we are looking forward to finding out like even some of those elements and how do we flow information and CRIS, which is the client health information system that sits in home care, is a bit of a backbone in the province, and so without having that there, people are having to find workarounds. We're going to actually see maybe how these workarounds work, and they've mostly done that on their own as opposed to going through like a central, you know, organized. So it'll be interesting to see that little bit. You did highlight and allude that maybe Janine's going to have some commentary around, and Janine's done a lot of I don't know how many things we can say that Janine's taken care of in terms of the infrastructure and enabling, and really having a lot of negotiation around, you know, how does the province and Ontario Health support these teams?
Yeah, well, I can speak specifically to the procurement, although I think Gaia brought up some of the challenges that we saw throughout the procurement, right? With, you know, OHTs have close partnerships with SPOs, and then all of a sudden we had communications blackout, and they couldn't collaborate with them in the way that they're, you know, used to working with their partners. But I will just say that what will be interesting to learn, Walter, is because of the new pricing model, the capitated payment model with stop loss, that's kind of innovative. And it was based on baseline data from home and community care was how it was developed. So we'll have to see over time how that plays out in terms of was that data accurate enough to inform that modeling. So I think that's going to be interesting to track over time. And we have a new quality and performance schedule. So the SPOs will be sort of working with their OHTs in the first 6 months to track certain measures. Some of them are related to your patient experience questions. So we tried to overlap where possible, where we're already collecting up data that could also be used to inform quality. So that was really nice to work with Kaylee on that. And there'll be an earn back model. So the vendors will receive an incentive or the teams will receive a credit based on their performance. I mean, there's a lot of caveats around it, the measurement and having the right end number and whatnot, but I'm interested to see how that works out. Overall, we learned a lot through the procurement, like procurement team learned a lot, and we came up with some specific recommendations that have gone to internal partners at OH and Ontario Health at Home who are looking at the future of contracting in the province. Like we had some lessons learned around, understanding the job market, communicating with the vendors, vendor development, and the timing for the procurement. But overall, I found the process, even though it was very difficult for the OHTs in their relationship building with the SPOs, working with them on the scope and requirements for the procurement was amazing. Everybody was super collaborative. So I think using that approach was good and was helpful, to have the end users of the product involved in determining, what are the things we're looking for and what the SPOs will be offering in these innovative models. So those are my comments on the procurement, but maybe Lindsay or someone from the OHT, they may have a different perspective, but that was my perspective.
Yeah, well, I think you also acknowledged in there some of the challenges that they had in terms of the relationships, right? And I think that's probably one of the bigger challenges that we heard about and understood. But I think there's been a tension between. The future of home care has to have some form of standardization to it across the province, but this is innovation, and innovation is kind of counter to standardization, and it's this tension that we're feeling, right? And I think being, operationally efficient and then also being very, client-centered, again, sometimes more tension. So we're going to learn a little bit more about that. Nisha, if you had anything to add about your experience and providing advice to the teams.
Yeah, thanks, Walter. Just wanted to say, these projects have been in development for the last, 3 years. Enormous effort on all the organizations' parts, the OHTs, OH at Home, MOH, and Ontario Health. We've seen a lot of resilience and agility and creativity on the part of the OHTs as they navigated the evolving provincial direction. I know it's not always easy. It's quite challenging to balance, provincial direction with the local innovations. But they've kept moving forward while keeping their partners engaged and keeping the projects moving forward. So just wanted to give a huge shout out to all the partners, all the OHTs in being patient with us and just continuing to be dedicated to the leading projects and moving ahead.
Yeah. I see people are going to be asking some questions, so I'll have to think about how do we share out more information. So for example, I don't know if you see it in the chat there, Glenda one's asking a question a bit more, this earn back model and different forms of procurement, right? It's been describing, I do some work internationally, and describing to my international colleagues about how we do procurement for home care in Ontario generally is pretty well leaves people kind of baffled. So thinking about new models that are a little bit more person-centered. And I think this idea of building in some earn back and performance and incentives is a whole new, it's an innovative way. So even within some of the backbone, we're really doing a lot of innovation, not even just at the front lines, right? So I think it's been really, really great. Lindsay, you play two, 3, or 4 roles here. You're an OHT, you're co-lead for the province, maybe from that provincial perspective, but you might want to add something from an OHT perspective as well. It's hard for when you're wearing multiple hats, so which one to answer from.
Yeah, I think we all my colleagues on the call have said a lot, and I think I won't repeat a lot of it, but I do think that this is really an opportunity to put into play all the pieces that we have heard, in particular from patients, families, and caregivers over the years, and really have a bit of a sandbox that we can play around with to test different ways of delivering care. And it hasn't not been a challenge in and of itself, but I do think there have been lots of opportunities to test and try things that are grounded in what we've heard from people would improve their experience and improve how they receive care and improve how people deliver care. So I think from a provincial, like the provincial sort of co-chairing perspective of this, we're really interested in how we can use these learnings, as Jon mentioned, to inform the future. And I think importantly, we're really excited to see the data. Some of the initial data we already have, even though very, very early days, it's really positive, and I think has started to really demonstrate some of those areas where we've seen underperformance or a lack, staff maybe not being as happy with their role and facing burnout. And really, when we're able to wrap a team around patients, how that actually improves care delivery and care delivery experience. So I think just high level, I would highlight that, and that we are working provincially with Ontario Health and Ontario Health at Home to really frame out how we come together and work together going forward around sort of the home care modernization piece as well. So I think that'll be positive to set up those principles and ways of working.
Yeah, and we really want to take the advantage of learning from these projects, because you wouldn't want to do this, I don't know, 7 times this much effort next time. To get out to scale to across all of the OHTs. I think it's really been a collaborative, and my experience of being involved in the many teams, while there are tensions, that people are all rowing in the same direction and acknowledging that. And while they come up from time to time, some of the challenges, people are willing to always kind of stay and have the conversation fully, and I've really appreciated that. And I think that's so heartening. And as you know, over the course of the next year, we're actually going to be live. We already are live, and learning and starting to think about, how do we tell this story? We're starting to tell the story a little bit today for others, because that's going to be a real value, because these teams are now working these bits out and understand what it's like to do this work and learning across the teams. But I think really it's going to be quite important for us, if we went back to our original evaluation questions, it's like, can we actually implement the things we want to implement? Can we actually make the changes we want to make the changes? And then really, how do we scale and spread this knowledge and make informed decisions for all of Ontario? And I think further abroad. I know internationally, Ontario Health teams are garnering interest as a program of advancing towards population health and integrated care. And this is where we're really seeing the integrated care space, because all of these people require integrated forms and models of care. There's nobody here who's only receiving services from just a few. They're all, as in my world, I might refer to these people as high users of the healthcare system. I'm a health economist, and some people know I've done some work in this space. And they all have multiple challenges: social challenges, medical challenges, functional health challenges, maintaining at home, and how do we actually really wrap care around them? So if we were to take a difficult place to work, we've found a difficult place to work. And I think overcoming challenges and some very, very great opportunities. And I think, Lila's got a question here about, how could home care be adapted to support a focus on chronic disease management and declines in function? It's interesting, because I think eventually, we're just starting out some work now related to the integrated care pathways. Some OHTs have been at this for a little while, and some non-OHTs have been at this for a little while, teams, and how do all these different lines of innovations and improvements start to come together. And I think we'll probably also hear a lot about primary care attachment and team-based care, which is an element to some of these practices as well. I think we've seen some of these practices being embedded in team-based community care. So there's lots to learn, and I think we'll probably be striving towards these models and improving Ontario's health system for many years to come. I want to extend a very large thanks to each of you from Ontario Health. I want to extend a very large thanks to John. You might come on and give a little wave goodbye. And to our team, for whom I am incredibly proud. It's an honor to work with Gaia, Kaylee, and Jessica. We have a few other team members, but this is a lot of what our team's been doing and working on in the last year and for the year ahead. And of course, obviously supported by all the teams. And I think there's just been massive interest as well. We're at a full hour and a half now. We still have 125 people online, which is just showing that people have really stuck and found this to be useful and informative, at least to hang on for the time. I'll say thank you. And this is not the last you have heard from the leading project teams. We'll be back through the course of the year, updating with some of the information and knowledge that we are gaining from the practices. I think there were some really nice suggestions from some people about hearing more from PFACs, and I think engendering more engagement primarily focused on the leading projects themselves will be a future edition in this space. And then coming back next year as we have some more follow-up results after implementation and some comparative bits. So I'll thank you all. I think we could probably say goodbye. For those people, we did pop a link in. All of our materials, this webinar, the slides will be available online. Fourth Thursday of the month, 40% of you hadn't been here before. We are here every month on the fourth Tuesday of the month from 12 to 1:30. Bringing you new and exciting knowledge from Ontario health teams and the health system across Ontario. It's my pleasure. I'm taking a little hiatus from hosting for a few months. I'll be off standing upside down on the other side of the planet, and I'll be back in July, but the team's going to be alive, and I'll drop in from all the way along. Thank you very much, and have a lovely afternoon, everybody.